pregnancy. And finally, we're going to talk about a forum about how to manage monkeypox in pregnancy. So with that, ladies and gentlemen, it gives me great privilege to introduce the first speaker, a colleague of mine, Dr. Leong Chi Lun, who's an infectious disease consultant in Hospital Kuala Lumpur. Now, Dr. Leong is not only a wise and experienced infectious disease consultant, but I believe he is one experienced holistic physician. And it is timely that he speaks to us about monkeypox and update. Dr. Leong, the floor is yours. Dr. Leong, you may start sharing the screen and start presenting.
Can you all see my screen now?
Yes, we can.
Can, huh? Okay. Yeah. Thanks, Dr. Muniz and the society that inviting me to give a presentation on monkeypox. And I'm actually learning because we haven't seen a single monkeypox in Malaysia yet. And most of my presentation is based on what we read in the journals, New England Medicine journals, and others that we are just reading and share our reading. Okay, monkeypox actually is.
Dr. Leong, sorry, can we have you in the full presentation mode and your video, please? Thanks.
Start video.
No, you can. Yep, and your presentation in a full presentation mode, please.
This is not a full presentation mode. I thought it's already full. Is this full? Are you see the full screen already? Hello? Can you all hear me, Dr. Muniz?
Yes, we can hear you.
Yeah. Is it full screen already?
Not yet. If you can just click on that icon.
Full screen icon. I don't know which icon to click on full screen.
Okay, no problem. Then let's yeah.
Can I just continue on this?
Yes, please.
Yeah.
Sorry, Dr. Leong, you can click slideshow. Sorry, click slideshow on the top. On the top, slideshow.
Got new slideshow.
Yes. On top, on the panel.
Yeah.
Slideshow. Go to slideshow.
There is no slideshow on the top of.
Oh, okay.
Stop sharing and share back. Stop sharing and share back. Now is it full?
Okay, so when you go down, there is a play button, Dr. Leong. Can you scroll downwards? Go to the right.
This one.
To the right some more.
Usually there is something.
Okay, no problem.
No, you just go slide.
Yeah, please carry on. Please carry on.
I just carry on. Sorry that I don't know which. Usually there is a button, but today there is no button for me. Also unlucky. Cannot right click. Nothing. Is this a?
Yes, the button is right. So the button is there now.
Oh, okay. Is it full screen already?
You need to press the play button once.
But no play button. Is it here? I worry I click something. No, not this one. pause. There is no more no other button to click.
Okay, no problem, Dr. Leong. Please carry on.
My wife is trying to now got now it's full.
Yes.
Am I right? Yeah,
Beautiful. All right.
Yeah. Okay. Yeah. Sorry. Yeah. Monkeypox is actually autopox DNA virus. Same genus with our variola smallpox virus. It's a zoonotic infection, and possible there is animal reservoir as well, particularly rodents. So because this is there is a reservoir in animals, I'm just making a joke here. I just recently, some people give a talk saying that why COVID-19 is so difficult to eradicate because there is animal reservoir. So no, now I don't know whether monkeypox is the same or not because there is also a reservoir in rodents. So as Dr. Muniz mentioned just now, is first described in humans long time ago in Democratic Republic of Congo in 1970. Since then, it circulated for decades in endemic area and never spread outside Africa. It's associated with contact with wildlife reservoir, particularly rodents, and such outbreak and travel associated cases outside Africa limited secondary spread, and therefore human to human transmission has been deemed inefficient. So there are two clades. The first one is West African clade, which the case fatality rate is up to 6%, and there is another clade called Central African clade, where the case fatality is higher, up to 11%. And before May 2022, this, as we mentioned, this monkeypox is endemic in Central and West Africa. But after May 2022, there is outbreak and spread beyond Africa. And after May 2022, there are sudden increase in cases to more than 20,000 cases. Is spread outside Africa and is spread in Europe, US, and other countries, in more than 70 countries, and now even more than 100 countries. So since early May 2022, more than 3,000 monkeypox virus infection has been reported in more than 50 countries across 5 regions. And transmission of monkeypox virus occurs through large respiratory droplets, close or direct contact with skin lesion, and possibility through contaminated fomites. There is no clear evidence sexual transmission through seminal or vaginal fluids. Vertical transmission and fetal death have also been described. And WHO Director General declared the ongoing monkeypox outbreak as a public health emergency of international concern on 23rd of July 2022. And that's why the whole world now is getting excited, and all of us are here learning about this monkeypox now. And looking at the publication in July 2022, New England Journal of Medicine, they mentioned that 80% of these cases are seen at outpatient clinic setting. Hence, it is important for primary healthcare professionals to know about monkeypox. So majority of these cases, you can see majority, 29% of the cases are actually seen in HIV clinic. And most of these cases are actually in between men who have sex with men. So that's why it raised a concern whether this is a sexually transmitted disease. And the second highest you see as outpatient is in sexual health clinic, which is 23%. The rest are actually small amount. And most of these cases are actually seen in primary healthcare facilities. I'm also concerned that to diagnose these cases is not easy because they're presented with rash. And if we want to have admit this patient for isolation, then only you can send specimens for swab. I'm worried that most of the cases may be underdiagnosed. probably we should open up and send the allow the primary care physician to send specimen, and the patient may or may not get admitted and get home quarantine. To force a patient to get admitted, also another issue. Some patients may not prefer to be admitted to hospital. They may not come forward to seek medical care. What we know about the clinical feature before current outbreak. So illness typically begins with fever, followed by the development of multiple papular, vesicular, pustular, and ulcerative lesion on the face and body, and prominent lymphadenopathy. So we look at here, actually the duration of monkeypox is quite long. The incubation period, generally median is about 7 days, but it ranges between 5 to 21 days. After the incubation period, which is asymptomatic, then the patient start develop fever, lymphadenopathy, headache, sore throat, malaise. And this febrile stage will last between 1 to 4 days. After the febrile phase of 1 to 4 days, they will go into the macular papular rash, vesicular rash, and so on. And this rash will be last to another 2 to 4 weeks. And after that, the patient will go into recovery stage where the lesion, the skin lesion becomes scabs. So the monkeypox rash are uniformly evolving. That is the key word here. In contrast to chickenpox, there is a differentiation between chickenpox and monkeypox where the rash may appear similar, but monkeypox, you can see the rash are uniformly evolving. In contrast to chickenpox, where various stages of development of the rash you can see at the same time. So in monkeypox, when there is macule, the whole body will be macule. And then they progress to papule, then you can see only papule. Then after that, they progress to vesicle, and you can only see vesicle, and then pustule, and then scab. So that's what I mean uniform. Whereas in chickenpox, you can see papule, vesicle, and pustule, various stages at the same time. So these are the textbook description on some of the rashes. And I see some of the rashes look complicated. And these rashes are quite big compared to the other viral exantheum or other viral illness. So this slide to show you the differentiation between chickenpox versus monkeypox. So the fever, actually both are actually have high fever. In both the duration of fever are also about 1 to 4 days. In contrast to chickenpox, where it's not common to have lymphadenopathy in chickenpox. So if you see lymph nodes, plus if you see a patient, you look like chickenpox, but you palpate lymph nodes, that is alert sign that you may want to admit this patient for swab and to send a PCR for monkeypox. The key sign is chickenpox plus lymphadenopathy. In chickenpox, the rashes are generalized all over the body. Is started on the body first, but in the monkeypox is centrifugal, where the lesion started on the palms and soles, and then they migrate centrally. So the migration of the rash is different compared to chickenpox, where chickenpox, the rash will come from central and then go peripheral, the other way around. So this lesion will progress, as I mentioned just now. In monkeypox, the progression is uniform. They go by all papule and then all vesicles and then all become scabs. Various chickenpox, you can see various stages, different type of rash at the same time. Yeah, this is to illustrate that there is another common rash that you see in primary care is nowadays hand, foot, mouth disease is also very common to see in primary care, especially in children and sometimes adults. Similarly, hand, foot, mouth disease do not usually has lymph nodes. So once you palpate lymph nodes, you have to think about monkeypox, and you have to admit this patient for investigation. And monkeypox do not usually have oral ulcer, whereas hand, foot, mouth disease will usually has a mucocutaneous ulcer. In hand, foot, mouth disease, the rash is actually much small vesicle, very small. Whereas monkeypox, the rashes are bigger, deep blister. Actually, when I look at the rash, it sometimes can mimic Penicillium magnificae in HIV infected patient. In hand, foot, mouth disease, the rash the distribution is more in the hand, soles, genitalia. And in monkeypox, is generalized with centrifugal distribution. The other common viral symptom that you have to think about it is measles. In measles, usually the fever will also about 1 to 4 days. Having fever first, you got corporic spot, and then the rash will spread from central to peripheral as well. So we need to know how to differentiate measles versus chickenpox and hand, foot, mouth disease. And all this, you can see the classical and the key point we emphasize again and again is lymph node. Whenever you feel a lymph node, you have to start thinking about monkeypox. Are there any newly reported clinical feature from current outbreak? New England Journal of Medicine has published about 528 infections between April to June 2022 in 16 countries. The median age is about 38 years old, and 98% are gay or bisexual men, and 41% are actually found in people who have HIV infection as well. So this raised the concern that whether this monkeypox is actually a sexually transmitted disease. You can see here, 95% have sexual close contact, and only on 26% have contact with person known to have monkeypox. So monkeypox virus DNA was detected in 29 of 32 persons in whom seminal fluid was analyzed. But this one need further investigation to see whether is it really monkeypox is a sexually transmitted disease or not. Okay, CDC reported the first 2 monkeypox cases in children in the US. So this also prompts that household transmission is important. It's not only sexually transmitted, because children don't have sex usually. So there are also when we found in children, it showed that household contact is also a risk factor for transmission of monkeypox. But one good news is transmission during brief interaction has not been reported. Is it always systemic feature followed by rash? Those with systemic feature are 61.5% develop systemic feature before the onset of mucocutaneous manifestation, about 40% systemic feature after mucocutaneous manifestation. There are about 12 to 13% has no systemic feature. Lesions were most commonly found on anogenital area rather than face and trunk, and 61% has less than 10 skin lesion. The site of lesion, we can see 73% are actually at anogenital area. Majority, they don't have a lot of skin lesion. They quoted 39% has less than 5 skin lesion. So most of the time, the skin lesion are found mainly on any anogenital area. In fact, some has single ulcer. Most are actually vesicular papular. You can see vesicle or papule. So that's why you can actually send the vesicle fluid for PCR testing. 41% have mucosal lesion. This 41% who has anorectal mucosal involvement, they usually also presented with anorectal pain, proctitis, tenesmus, or diarrhea. Those with oral pharyngeal symptoms include pharyngitis, odynophagia, means they may have difficulty on swallowing. They may have epiglottitis, so they may present with hoarseness of voice, and they also have oral or tonsillar lesion. So those patients who has oral pharyngeal symptom, you can actually same like doing a COVID-19 swab test. You can send the throat, tonsillar swab or throat swab for PCR. More than 50% has lymphadenopathy, and this has been emphasized again and again. And 79% of the patients are actually having inguinal lymph node. So now it shows how important when you see a patient with chickenpox, measles, or hand, foot, mouth, do not forget to examine all the lymph nodes. If you found a lymph nodes, then you raise a suspicious to remember to send the specimen for monkeypox PCR. In order for us not to lose to Singaporeans, they already found cases in Singapore, and yet we haven't found any case in Malaysia yet. Other clinical features, similar clinical presentation among persons with HIV infection, but in this cohort, majority were stable patients with suppressed viral load. 29% has concomitant other sexually transmitted disease. 8% has gonorrhea, 5% has chlamydia, and 9% has syphilis. Incubation and infectivity. The mean incubation period is 7 days, but the incubation period can range from 3 to 20 days. The median time from onset of symptom to the first PCR result was about 5 days. And the median time from development of the first skin lesion to the development of additional skin lesion was 5 days. In person for home data on follow-up PCR testing were available. The latest time point at which a lesion remained positive for 21 days after the symptom onset. So the PCR can be positive up to 21 days for those patients has a skin lesion. So the infectivity will probably last up to 21 days. CDC, one is infectious, one symptom begin until all the scab fall off and new layer of skin is found. So that is the infectivity period. UK HSA advises condom use for 8 weeks after the infection in order not to transfer the disease to the spouse. What are the complications of monkeypox? The complication actually I see here, it mimic chickenpox. Chickenpox, we can get chickenpox pneumonitis and encephalitis. And in monkeypox also, you may end up with pneumonitis. They may present with difficulty in breathing, encephalitis, abnormal behavior, myocarditis, keratitis, the redness of the eye, or secondary bacterial infection on the skin. The risk factor for severe disease is based on the previous outbreak, the higher in pregnant women, younger children, and also immunocompromised patients. How many patients were admitted? There are in the New England Journal Medicine article that collected, only 13% of patients were admitted. And why are they getting admitted? Number one, for pain management, mostly because of the severe anogenital pain. Second is skin and soft tissue super infection. Third is pharyngitis. Because of the epiglottitis and pharyngitis, they have sore throat so severe until they are not able to take orally. That is 5 patients. Some are admitted because of eye lesion, some acute kidney injury, and then some admitted because of myocarditis. 13% in admitted just because of infection control purposes. There is no difference in the frequency of admission whether you are HIV infected or non-HIV infected. The case fatality rate has been actually lower compared to the cases in the traditional way. You can see when this started in 1970 in West Africa, case fatality rate is about 40%. When it in 1981 and 1998, the case fatality dropped from 9.8% to 1.5%, and now the case fatality is actually very low. So what about the current case fatality? There are one death in Spain, 2 deaths in Spain, and 1 death in Brazil, 1 in India, and 1 in Ghana. So up to the reported here is only 6 deaths reported to in the non-endemic countries. Laboratory diagnosis is important. As I mentioned, whenever you see a rash now with lymphadenopathy, diagnosis can only be confirmed by RT-PCR, and in the hospital, we need to send this fluid specimen to Institute of Medical Research, IMR, or in the Klinik Kesehatan, you can send to Makmal Kesehatan Awam Sungai Buloh, MKAK. So what are the specimens you can send for lab diagnosis? Site of positive monkeypox in viral PCR are skin or anal genital lesion, nose or throat swab. You can also send blood sent in EDTA bottle, same like the bottle we send for HIV viral load, or you can send urine, and you can send seminal fluid. So this is a chart that how you send the specimen. If the patient has vesicle or pustule, you take the lesion fluid, you deroof the pustule, then or you can even biopsy and send for PCR. The scab and crust of the lesion you can also send for PCR. If the patient only presented with fever and tonsillar lesion, or as I said just now, pharyngitis, epiglottitis, then you can send tonsillar swab or nasopharyngeal swab, put it in a viral transport media and send to IMR. You can send blood, put blood into the EDTA bottle, same that we put HIV viral load bottle, and send to IMR for PCR for monkeypox. So all these are the top 3 are the PCR testing. For the patient has a post rash where you are suspicious but you miss the boat of sending PCR, you can also send convalescent serum. I'm not sure whether antibody can be done or not now, but usually antibody, you can send serum for antibody, and the IMR usually can help to keep the serum. In our KKM case definition, a suspected case is a person of any age presenting in a monkeypox non-endemic country with an unexplained acute rash and one of the following sign or symptom: headache, acute onset of fever with swollen lymph nodes, myalgia, back pain, and asthenia, and for which the following common causes of acute rash do not explain the clinical picture. So if any of the rash cannot be explained by chickenpox, herpes zoster, Zika, measles, chikungunya, or lot, then you should start suspecting this patient has a monkeypox. So I think this is a bit difficult to digest. For me, to make it simple, any rash with lymphadenopathy, better start alert that this may be monkeypox. Probable case actually fulfill one of the following. Probable is always has an epidemiological link to a positive patient. So we always say probable MERS-CoV, probable COVID-19. Actually, when you say probable, it actually has an epidemiological close contact with a positive patient, and then the patient develop fever, and then rash, you said this is a probable case. And confirmatory case is only after the lab result come out as PCR positive. That is a confirmed case. So come to treatment. Mainly supportive treatment, as majority of the cases are mild and self-limiting. only 5% of the case series receive antiviral treatment. And what are the antiviral treatment available? Actually, the following. There is a new antiviral called tecovirimat, which is a new antiviral. Later, Dr. Gayatri will tell you that this antiviral can be also given in pregnancy, less side effect. The other drug that actually more traditionally I know of is cidofovir. Cidofovir is actually a very potent antiviral. It's a broad spectrum antiviral. It can also use for adenovirus, but I hardly use this antiviral in Malaysia because this cidofovir is very toxic. It has very high renal toxicity. So we don't actually use this cidofovir commonly. And the next is can use vaccinia immunoglobulin if the patient has severe disease. So antiviral tecovirimat, which is a pan-autopox P37 inhibitor, which prevent virus from leaving the infected cell. It prevents that in little challenge monkeypox and rabbit pox in animal models. So this has been used. The other one that I mentioned just now is cidofovir or cidofovir. Previously can also be used for adenovirus. Cidofovir is very toxic, but cidofovir claim they are less nephrotoxic compared to cidofovir. Okay, last come to vaccination. At this point, mass vaccination for monkeypox is still not required, but there may be a role for pre-exposure prophylaxis in high-risk exposure. And also there may be a role for post-exposure prophylaxis. As I discussed with other panelists just now, I'm also learning, and when I see all these recommendation on vaccination, this is the first time I see CDC recommendation of using vaccination as pre-exposure prophylaxis. Previously, like in COVID-19, we will never use a vaccine as a pre-exposure prophylaxis. They probably can they can prevent severe diseases. And this is the first time also I see CDC recommendation using a vaccine as a post-exposure prophylaxis in close contact patient. Okay, how about preventing transmission of monkeypox in healthcare facilities? As usual, thanks to the COVID pandemic, so whenever there is any new novel disease, infectious disease coming, the first thing we are thinking is admit all of them to isolation ward. So it's an early rapid recognition and triaging and source control. So at the current moment, when the cases are actually not a lot, if we can still cope, the recommendation is to admit them to isolation ward. And then rapid case identification at entry point, a high index of suspicious. Whenever patient has rash or lymphadenopathy, we need to send specimen. Without sending specimen, we may not be aware that there are monkeypox cases in our region. Visual alert at entrance to emergency department, outpatient clinic, instructing patient or visitor to inform healthcare worker if he has symptoms related to monkeypox, then he has, if in fact he has a close contact with anyone who are suspicious to have monkeypox, so that we can isolate them as soon as possible. Okay, suspect, probable or confirmed case should be isolated. Ideal situation in a negative pressure room, but we do not usually have enough negative pressure room. So if not, we can isolate them in a single room with door closed, or even cohort them. And we need to apply standard contact and droplet precaution. And in addition, because of the theoretical risk of airborne transmission, airborne precautions should be applied whenever possible, because it was the virus is being seen as a large droplets, so we still need to wear N95. But for me, if this is a droplets, I will say maybe a face mask may also adequate. So this is the current recommendation. if you see a patient with monkeypox, as usual, when any emerging viruses which is new, where our knowledge is not adequate, we will also start with a very protective way first. Wear N95, face shield. You need to wear isolation gown. Especially this is a forum that initiated by our ONG colleagues. When you deliver baby, there is splash of lye-qua, so you really need to wear an isolation gown. You need to wear glove and eye protection to prevent the lye-qua splash on your eye. I can make a joke, lye-qua splash on my eye if I don't if you deliver a baby without wearing eye protection. Then you start looking for Dr. Muniz, what should I do? So this is the community awareness to prevent that people, to alert people that to report ourselves if you are actually coming from affected country. But now getting more and more country being affected, I also cannot remember what are the country being affected. So you need to go back to CDC and ask CDC what are the country being affected. Previously, it's more of Cameroon, South Africa, Nigeria, and then after that, it's spread to Australia, Belgium, Canada, and now getting more and more country being affected. So take-home message: unprecedented community transmission of monkeypox is not in non-endemic country are occurring nowadays. Rapid identification and diagnosis to contain further community spread is important. And although majority were gay, it is not a gay disease. Even children can get infected. So anyone could get it, not to stigmatize that this is a gay disease. They may have atypical feature. They need to consider monkeypox at risk person presented with traditional sexually transmitted disease symptoms. That's all that I'm sharing with you all. Thanks for inviting me again, and I would leave Dr. Muniz to moderate for the question and answer later. Thank you.
Thank you so much, Dr. Leong. That's a wonderful overview on monkeypox. So just to recap what Dr. Leong has highlighted, I think a triad of fever, rash, two things about the rash: location of the rash, if it's in the anogenital region, and the uniformity of the rash should increase the suspicion towards perhaps the monkeypox. But apart from fever and rash, the third triad is lymph nodes. So that is one important key point from Dr. Leong's talk. Although we often think that it is respiratory droplets and direct contact, I think now the evidence is evolving that perhaps it is also transmitted via sexually transmission. And that is one other important point. If you're non-pregnant, the case fatality is extremely low. Treatment is supportive. But how about pregnant mothers who are vulnerable? Should we just treat them supportively, wait and watch? Or should we treat them with antiviral, TPOXX? Do we need to vaccinate pregnant mothers? I need to talk about monkeypox specific to pregnancy. I'd like to invite the next speaker. I'm privileged that the next speaker is agreed kindly to speak all the way from UK, half the globe across, Dr. Gayatri Mariappa. Now, Dr. Gayatri is the next rising star of maternal medicine. She's almost towards the tail end of her training in UK, and she's going to talk to us based on her experience about management of monkeypox in pregnancy. Dr. Gayatri, we are all ears for your talk.
Thank you very much for the kind introduction, Dr. Muniz, and a pleasure to present today. Let me share my screen. All right. Are my slides being seen?
I think.
And am I audible?
I think the tech expert, we need to stop sharing your screen, please.
Can I?
Perhaps you can stop sharing and start sharing once again.
Okay, let me try.
Yep.
Now?
Yep. We can.
Okay, perfect. All right. Thank you very much, Dr. Manis. Thank you, Dr. Leong, for a very, very extensive lecture and comprehensive and makes mine much easier. So let's start off with, again, about the virus. I know Dr. Leong have explained, but just a recap again, a bit of virology back to our medical school days. It's an enveloped double-stranded DNA. It's from the Autopox virus genus. The family is the Poxviridae, similar to the smallpox. But what's important here I want to stress is regarding the two distinct genetic clades also known as strains, which is the Central African, which is the Congo Basin clade, and the West African clade. The difference being Central African, once we send the monkeypox PCR, we need to know which strain, as the Central African has a more severe disease and is more transmissible compared to the West African, which is milder with lower mortality. So when monkeypox was first known, this goes back way to 1958, hence the name, as it was first discovered in laboratory monkeys. So then later on in 1970, we had a first identified case in Africa, where there were concerns maybe it might look like a smallpox like illness. And there were subsequent outbreaks hugely in Congo, where there were about 88 case series present. And this was quite quiet until when it became endemic in Congo, then later in June 2003, when the CDC announced an outbreak for the first evidence of community-acquired monkeypox in the United States. And this came about when rodents and cargo was transported from Africa, and when the prairie dogs were exposed to these animals, brought the infection back home. So in July 8, there were 71 cases across 6 states in the United States. So what do we knew about monkeypox in pregnancy? So with this similar outbreak, there was the smallpox vaccine that was usually used before to reduce risk of monkeypox among previously vaccinated persons in Africa. So what CDC recommended then in the US, that anyone exposed to this sick prairie dog, or if the person it can be vaccinated, regardless of their pregnancy status, were given the smallpox vaccination. And again, to note, even though a pregnant woman, if you imagine a woman has a prairie dog who's sick, has a pet at home, and she's being exposed with her unborn fetus, she was still being vaccinated. So what was the case series that we have in monkeypox in pregnancy? These were 4 pregnancies done among the Congolese women with monkeypox infection. This was back in 2011, which was part of this paper in the American Journal of Tropical Medicine. Sorry, it's a bit of a busy slide, but just want to show regarding the 4 cases. What was the conclusion is it has a very high abortive rate. And you can see from the first case, we have an 18-week loss, and the fetus develops hydrops fetalis, specifically hepatomegaly, and this was diagnosed on necroscopy, and also diffuse cutaneous lesions, similar to what happens on the mom. The second and third case had early first trimester miscarriages with high viremia load and more than 1,000 lesions, which I'll explain shortly regarding severity of infection based on WHO. But only 1 woman had a low viremic load, low lesion count, was infected at 14 weeks, but went on to have a safe pregnancy outcome, and the baby was well after. So why is it re-emerging after 40 years of it being very dormant? It was endemic in Congo in 2007. It's because there's improved transmissibility. We know that the virus can adapt to the human host, is very smart, and is promoted by the increased exposure of this immunologically naive population to autopox, because most of us are not vaccinated against smallpox. So how is it transmitted? We know the death rate is about 3 to 6%, and the spread is in 3/4 of them, it about contact with lesions, bodily fluids, contaminated materials, and through respiratory droplets. So the characteristic features, I thought it would be easier to understand if you can remember, as SPR squared, Firstly, skin lesions. Again, just reinforcing what Dr. Leong mentioned, you get firm, rubbery, well-circumscribed lesions. It can involve mucous membranes, genital, anorectal areas. It goes through 4 stages before becoming a scab. So S is for skin. Oops, sorry. P is for prodromal symptoms, where you have a fever, chills before the rash, mostly malaise, myalgia, low energy, and importantly, lymphadenopathy. Interestingly, it has rectal symptoms. You have purulent or bloody stools, pain, hematochezia, and this can or may be related with the lesions around the anorectal region. And of course, the other R, respiratory symptoms. It may affect, you can have some mild upper respiratory tract, sore throat, nasal congestion, and cough. So again, about the lesions to differentiate between the most commonly encountered lesions that we see is chickenpox, that this develops simultaneously and it evolves together. It doesn't come in crops. It's centrifugal, extremities and face first, and the lesions relatively are the same size and at the same stage of development on a single side of the body. Meaning if it's about 2 centimeters, the same lesion would progress accordingly to the stages which I'm showing on my right side of my screen. And they are often described to be painful until they become crusty and become itchy thereafter. So the stage 1 is usually macules, followed by papules, vesicles, pustules, and then scab. And a person is known not to be infective once the scabs fall off and new skins forms. So these are the varied monkeypox lesions on different kinds of how it is over the face. It's very difficult to look at first, but I think history, examination, and diagnosis will aid us further. So again, about the, this is from the CDC. Again, you have enantium, usually lesions in the mouth or tongue, followed by macules, papules, vesicles, which are all about 1 to 2 days, then forming the pustules and the scab, with a total of 14 days of skin lesions. So what to do if you suspect a person having monkeypox? This is again by the CDC. Yes, we asked the patient within the last 21 days, have you traveled to a country with recent monkeypox cases? But I guess that this might not be very helpful at the moment because knowing that there's so many 100 countries, if I'm not mistaken, which are being, which have cases reported. So it'll be difficult at 2 a.m. in the middle of the night that when you're seeing a patient and going through which of the lists that you have traveled to. Anyone has a close or intimate contact with someone with a similar rash or a confirmed monkeypox infection, or within intimate contact with a social network. So what are the risks to pregnancy? You have miscarriage, preterm birth, stillbirth, severe hemorrhagic disease to the mother, but this is only an isolated single case report, so we can't say it's entirely due to monkeypox. And congenital monkeypox infection, meaning that based on WHO, we know that the monkeypox can be transmitted through the placenta to the baby, hence the congenital monkeypox. So let's move on to what we are very keen to know about treatment modalities. Firstly, precautionary, vaccination, pre and post-exposure prophylaxis, and antiviral treatment. So if you have a suspected or a confirmed monkeypox infection patient, I'm just repeating, I'm sorry, but a few things that I would like to mention. Special air handling is not required. And if you need to transport patients, we know pregnant mothers, we need to send her for a scan, or if she goes into labor, make sure that it's she's in a single person room, dedicated bathrooms. And if you're going to transfer, make sure she's on a well-fitted medical mask and cover the exposed skin lesions with a sheet or a gown. And the doctors and the healthcare people who are attending to the mother to ensure proper gown, gloves, eye protection, and 95. And of course, when I was reading, there's about waste management, about depending on the virus clade, also there's the disposal can be different. So do not hug, kiss, touch, or anyone with an unexplained rash. Do not share utensils. Avoid contact with sick person's clothing or bedding. Refrain from sex if your partner has a visible rash. not being stigmatizing to the homosexual, heterosexual population. Use condoms if you're and your partner are not monogamous. Wash your hands. I think all of these are pretty common. We are all professionals after battling COVID. And of course, avoid contact with wild animals. I have a very cute Chip and Dale over here, but we know that squirrels don't go and pet them as they're one of the host reservoir for the monkeypox. So coming to this very good paper that can guide us on a clinical management algorithm for suspected monkeypox exposure in pregnancy. This by a group of very established people by Pradeep, Karin Nelson, Citra, Didier, Paul, and David. They are from varied countries from the National University of Singapore, Los Angeles, France, and also Lausanne, Switzerland. I know it's a very busy picture, which I will show shortly. So if you're a pregnant mother who suspected monkeypox, you feel that she might have, traveled to a recent country, close contact or exposure to an unusual or exotic pet, you do a clinical examination, again with full PPE, airborne and contact PPE. Then you decide if she's asymptomatic or symptomatic, and that will help us tailor the management. Asymptomatic, you do a monkeypox real-time PCR, oropharyngeal swab, as mentioned before. The blood, vaginal fluid, or urine can be considered, but mainly best will be on the lesion itself. If she's symptomatic, if she has a skin rash, genital lesions, fever, headache, lymphadenopathy, sore throat, then again, still proceed with the same swabbing. And here, if the results come back to be negative, we can stop monitoring in an asymptomatic woman. But if it's positive, what is recommended is for home isolation for 21 days, no visitors, self-monitoring. And of course, during that point, if she develops symptoms, you escalate to the right side of the table. And we can discuss autopox vaccine, which is post-exposure prophylaxis. It is best given within the first 4 days. However, if need to, if there's absence of symptoms, we can give it up to 14 days. And the benefit, it can reduce the severity of symptoms if you do eventually get the monkeypox infection. So regarding isolation at home, but recommended by the local Ministry of Health of Malaysia, is at the moment, since we are not exposed, we are all very naive, we don't know about this disease, best to isolate the women at our local healthcare facility. So again, even though the mother, so if she's tested to be positive, but she's asymptomatic, we still need to monitor the baby, serial growth scans, umbilical artery Dopplers, and of course, monitoring for evidence of hydrops, particularly looking at hepatomegaly. Role of amniocentesis, we can discuss in a while, but how about a mother is symptomatic and she's tested to be positive? It will based on the WHO clinical severity score, looking over here, mild, less than 25 skin lesions, moderate, 25 to 99 skin lesions, severe infection when she has 100 to 250 skin lesions, and a very grave disease if it has more than 250 skin lesions. And this can be seen like in the case reports I mentioned earlier. So what are the maternal surveillance? Making sure we have a mu score always closely monitored, her temperature, heart rate, blood pressure. Antibiotics are mainly for bacterial superinfection of the skin and the orogenital lesions. Tecovirimet, which was mentioned earlier by Dr. Leong, and I will explain shortly specifically on that, vaccinia immunoglobulin, and the vaccine. Cidofovir, again, it's advised to be considered only in critically ill women because 1, for the baby is teratogenic, 2, it is nephrotoxic to the mother, so there's more risk, so we need to see. And of course, fetal assessment and corticosteroids can be given accordingly if need to. So what about delivery? Of course, with any infection, predisposes a mother to preterm birth. It can be done on site as long as we have an isolated room, negative pressure. C-section is not superior. We would aim for a vaginal birth, except if there's presence of a genital lesion. And of course, we need to alert our important neonatal colleagues about monitoring the baby and testing the newborn. And we need to have a local policy for babies with mother exposed to monkeypox. So what are the treatments that are available? Tecovirimat, which is the approved treatment for smallpox, can be used in monkeypox. Cidofovir and brincidofovir, teratogenic effects on animal studies, so we generally would like to avoid. Vaccinia, which is an immunoglobulin, and monoclonal antibody treatment is still under investigation, and we still need to watch the space for further information. So what about tecovirimat, TPOX, or ST246 it's called? It's basically an antipox antiviral. It's a first line for pregnant women, recently pregnant or breastfeeding. It's FDA approved for smallpox in adults and children, hence we do not exclude our pregnant women. We don't have any human data available of its use in pregnancy. However, when there were animal studies done, they actually dosed these animals 23 times higher than the recommended human dosage, and still no fetal effects were observed. We are unsure if by giving tecovirimat to all our pregnant mothers at the point of diagnosis, does it prevent congenital monkeypox? We don't know. We can use for people with lesions, eyes, mouth, and a positive PCR. And it can be used during breastfeeding. However, if the children with monkeypox are breastfeeding to the mother, we need to treat this infant separately, because whether the antiviral can reach substantial amount in the breast milk to the baby is very minimal. So it'll be safer to do that for treating the children separately. What about this vaccinia immunoglobulin? We don't have any animal studies yet. It's not known to cause any fetal harm. IVIG is widely used in pregnancy. So when do we actually give this immunoglobulin? When a person has the vaccine complication, a mother has severe infection and she's sepsis, or as a post-exposure prophylaxis in a person who has a severe immunodeficiency in the T cell function. So not really as used as post-exposure prophylaxis for, we would say, in a otherwise healthy individual. So what do we learn? Lessons must be learned from COVID-19. This is a very nice paper just released in the Lancet in 2022. If you see all our names, you can see our current RCOG president there, Mr. Edward Morris. So what is this vaccine? MVABN. It's a modified Vaccinia Ankara vaccine. I have no disclosure of interest for this. It's a further attenuated version of the virus. It's known in many names. In Canada, it's Immune, Imvinex, Ingenious in the US. How efficacious is it? 85% protects against monkeypox. But what's important about this, it's a live vaccine. However, it's a non-replicating. So it's a live non-replicating vaccine. So what's important, it's inability of the virus to replicate in a vaccinated individual, in contrast to the original smallpox vaccine. So what happens is replication cycle is blocked at a very late stage. So the virus are not generated and not released in the human body, meaning the virus cannot spread in the vaccinated person, hence safe in pregnancy. There's no vaccine against monkeypox is approved at the moment. However, we can use it in breast milk, unlikely to pass into breast milk, and should be encouraged to be vaccinated if exposed. Why do we consider giving in pregnancy? Again, non-replicating vaccine. So far, animal studies did not find any adverse fetal effects. Current data, which is available in less than 300 pregnant women, no increase in adverse outcome. And we need to weigh the possible benefits of whether preventing a monkeypox infection or actually the potential unknown risk of the vaccine itself. So what's the current recommendation of the monkeypox vaccination? Vaccinate contacts of confirmed cases. Healthcare workers can be used as a post-exposure prophylaxis up to the 14 days as it reduces severity of symptoms. And again, this very new thing that we all learned is about pre-exposure prophylaxis for healthcare workers who likely will encounter patient with a suspected monkeypox infection. And it's usually 2 doses, 28 days apart. So again, we need to learn from COVID-19 that healthy mom, healthy baby, healthy future, pregnant women must not be excluded from early studies of vaccine, as women can benefit early. The more data we can have a safety and effectiveness of any kind of therapeutics for the mother. So how can we all help? I know we have not seen a single case yet reported in Malaysia. Are we testing enough? Are we not? Are we not aware? So if we do, I think providing to this European registry in Switzerland will help for us to know more about this condition. So with that, my take-home messages: monkeypox versus chickenpox. We know the rash occurs at once, not in crops. Vaccinate exposed pregnant women to monkeypox infection. But again, outweighing both risk and benefit. Tocovirimet can be used in pregnancy. It could be a sexually transmitted infection, not saying disease. We learned from COVID-19, we should include all pregnant women in vaccine and therapeutic studies. And of course, international registry, notify for data collection. With that, these are my references, and happy to go on to our next part of the our talk today.
Thank you very much, Dr. Gayatri, for wonderfully summarizing the management of monkeypox in pregnancy. So some take-home messages from your wonderful summary. I think we have highlighted that pregnant mothers are vulnerable. Although the general consensus is for supportive care, I think antiviral, if needed, is not contraindicated. In fact, pregnancy is listed as one of the indications to start antiviral. It's going to be TPOX. You wonderfully summarized. I like this fact about the age-old perception that live viruses are contraindicated in pregnant mothers, but this new non-replicating live virus, I think that's an interesting concept that you highlighted. So I think we've got about 15 minutes. Let's debate, discuss, argue, and come to a consensus. The disclaimer: none of us are experts. We are learning on the job. I've got a difficult question to Dr. Leong first. Dr. Leong, Ebola came, we were criticized because we were late to react. COVID came, the implications was significant. Should we now be worried with monkeypox, or will it just disappear like smallpox?
Okay, thanks, Dr. Muniz, for the challenging question. Yeah, there is after I learned from the COVID-19, I always feel that now I'm telling people, maybe I leave it to the public health intelligence to predict the future. As a clinician, I find it luckily I'm not a public health expert. I find it very difficult to predict the future. Whether the monkeypox will be, shall we be concerned? Yeah, surveillance and surveillance and surveillance and surveillance is the answer. We need to tighten our surveillance. We need to create our awareness, and we need to welcome people coming forward for seeking medical attention. If we are jailing them out, and they may be they may just avoid to seek medical care because they don't want to be jailed, and we will never have a monkeypox positive in our country. So I find that we really need to do more surveillance and welcome people to come forward to seek for medical attention, and send investigation more so that we can identify. Then only we know, shall we alert and shall we do more preventive measure, and we were never able to predict, and we should be always on high alert that is maybe at our doorstep. Too scared of something is not good. Too lenient, don't care, also not good. So that's why we need to come into the middle and be alert and continue tight with our surveillance. I hope I answer the question.
Yes, wonderfully, Dr. Leong. So any patient that presents with fever, rash in the anogenital region, which is uniform, and lymph nodes screen, and the screening test is actually a swab PCR, which is easily available in a lot of centers in Malaysia. Now, coming about screening, Dr. Leong, one more question is the PPE. I think people often debate that we sometimes overdo or sometimes we underdo. Now, what is your perception based on current scientific evidence about monkeypox? Yes, condom, barrier method of contraception is important, but to healthcare givers, what is the recommended PPE?
Yeah. I am always feel that because thanks to the my hospital and asking me to chair the infection control, it made my role more difficult. I have to be holding to the motto of kepimpinan melalui teladan. So I have to say that prevention of spread and prevention of hospital outbreak is utmost important. So I have been trying my best to comply to PPE, but I also learning from COVID-19 that when I am too comply to PPE, sometimes I jeopardize my patient care. To be very honest, this is from my own experience. I wear a full PPE, I wear N95 mask, I wear isolation gown, I wear face shield. I look at the chest X-ray also, I don't know what I'm reading because I'm getting older. My spec also, my vision is also getting more not that perfect. So when I wear too tight PPE, I'm not sure whether I'm seeing my X-ray or CT scan well enough or not. And some this monkeypox especially is more contact precaution rather than airborne precaution. So we have been isolating our folder, our case notes, our CT film. We said we need to sterilize before we go and touch them after for the sake of infection control, so that we want to prevent outbreak in the hospital. So when we isolate all these case notes, when we see the patient, we don't have the case note. When we see the case note, we don't have the patient. We see the patient not die yet, but actually the potassium is 2.1. So there are pros and cons wearing tight PPE. So I will urge our clinician, they are always weigh the benefit against risk. So too tight on infection control, we may compromise patient care. You may say that, oh, this patient is recently getting infected. If they are having, I hope this is not happening, upper GIT bleed. Always I heard, oh, wait for off-tech before I do a scope. Wait for off-tech before I do a bronchoscope or even OGTS or anything. I'm not saying any. I hope it's very general. Not everybody are doing the same. There are people who are hero as well. So we always think about benefit versus risk, infection control versus safety of our patient. On one hand, we cannot allow outbreak happen in our hospital. So I do agree that we maybe learn from the very high before. If we want to reach the moon, we need to learn how to. I think my mother always said, if you expect to reach the moon, you probably got to go up to a tree first. So I do agree, Dr. Muniz, that I need to learn the way of we wear PPE, like we facing Ebola. Yeah, you're right. When come with Ebola, it can be airborne, it can be contagious. Even splash of laqua or any secretion, you can cause outbreak in our hospital. So I do feel that we should learn the tightest, the highest level of PPE. But when time comes, when we see the care of our patient being compromised, sometimes we need to modify and cut down some of the PPE when necessary.
You're a physician at heart. You believe in look, listen, touch, and feel.
Yeah.
What is clear about monkeypox? It is not respiratory airborne like COVID, but it is respiratory droplets. So casual contact, the risk is low. It is more of direct contact.
Yeah.
Now, the next 15 minutes, Dr. Gayatri, this is a webinar on pregnancy. We're going to change our focus to you. Now, it is very clear, based on our experience from malaria, chickenpox, and COVID, pregnant mothers are vulnerable, especially because of the physiological adaptations. Now, having this experience, how differently do you think we should be proactive in the management of monkeypox, which is going to be different than non-pregnant mothers?
Okay, a very good question, a tough one indeed. Yes, we all know we have learned a lot from the flu, COVID, that pregnant mothers, there's a lot of physiological changes, immune adaptation, and very strong evidence that we have with COVID that as the mother enters the third trimester, there's further hormonal interplay with the immune status that makes her more vulnerable for infection. She may be low risk or has much more added risk, her age, morbidity, social circumstances that makes her more vulnerable to infection. And we know that with pregnancy, we have this point where the mother can get a severe infection, meaning requiring intubation, ITU care. But how can we change for monkeypox? I think it's being aware that this exists, that we need to be, all of us need to be aware, check, test, and if we do, treatments are available regarding post-exposure prophylaxis, antivirals. Of course, all this comes about, we know theoretically everything is, it can be given. There is limited fetal effects, limited concerns for mother, but it's about weighing the risk versus benefit. We need to have a multidisciplinary approach, not only the infectious disease colleagues like Dr. Leong, the maternal fetal medicine team, the neonatologists, our counterparts, the anesthetist if needed in certain cases, and of course the patient herself, that she's agreeable for treatment to go on forward. So that it's I think it's something very new, so we need to discuss before we actually go on, but being ahead, 2 steps ahead and knowing about it is very important.
Excellent.
Yeah,
Thank
hope
you,
I've
Dr.
answered.
Gayatri. Yeah, so I think supportive care, if non-pregnant, once pregnant, perhaps if needed, if high viremia or in moderate to severe cases, antiviral, TPOX is not contraindicated. I think you highlighted that wonderfully in your talk. As an obstetrician, they often ask 2 questions: when to deliver, how to deliver, does she need a cesarean section, can one breastfeed?
Okay, so our bread and butter. Do we need to deliver a mother if she has monkeypox? No, I would say it would depend on the clinical situation. If she's purely coming for an infection herself, we will need to treat the mother first, treat the infection. And of course, we know that any pregnant mother with having an infection, she is more susceptible to a preterm birth. So then again, we need to decide and, think about role of steroids and fetal lung maturation, but that can be always given later. How to deliver, we aim for a normal vaginal birth, knowing that cesarean section has its own morbidity and risk. But bearing in mind, if there's evidence of genital lesions, because if this ruptures during birth, again, direct contact to the newborn baby, so that would need to take consideration. Breastfeeding, for now, I mean, I won't say, I don't have a scientific reason for it. I would say it's more logical. Again, we know how it's transmitted, bodily contact, direct contact. So if the mother has skin lesions around her breast or her nipple, I would say stop. And we know how the natural history of the disease. It's about 2 weeks from starting of the rash to resolution and scab falling off and new skin forming renders her not infective. So, I mean, during that period, the mother can express and dump her breast milk, and then she can continue breastfeeding. But that doesn't mean you should isolate the mother and the baby from the start. Yeah.
Thank you, Dr. Gayatri. Wonderfully addressing every single obstetrician's concern. Now, there's still no questions from the crowd. While we wait, I still have got plenty of questions. Dr. Leong, traditionally, live vaccines are contraindicated for pregnant mothers. And traditionally also, we don't use vaccines as a post-exposure prophylaxis. But I think this is something new because this non-replicating live virus, which I just read in the last few days, is now being recommended. And the vaccine is also recommended even if someone has got the infection. Now, in an infectious disease specialist point of view, what are your thoughts about this new evolving science?
Dr. Muniz, I'm excited and I see that people use vaccine as a pre-exposure prophylaxis. I'm thinking of it while waiting for your question. So now I think I can answer this way. Okay, you look at influenza. Influenza pre-exposure prophylaxis. Before the vaccine era, we actually there is a time that we said use antiviral. In fact, using antiviral for pre-exposure prophylaxis is doable if the antiviral has not really have a lot of side effect. We cannot give prophylaxis using an antiviral that is very toxic. So we see just now the potent antiviral actually is quite toxic. I'm not I'm still new to the other one, the ticolimab. I'm not sure, but cidofovir definitely cannot be used as a pre-exposure prophylaxis because it's very toxic. Otherwise, I can use my cidofovir for a lot of even CMV. We never use that, so we cannot use we cannot use antiviral in this scenario because the antiviral is very toxic. So in that scenario, we have no choice to use a vaccine. But this vaccine, I'm curious because usually whenever people ask me, when you inject vaccine, when is it time to take effect? It's usually about 1 to 2 weeks. That's why I'm a bit curious. At this time, CDC actually recommended vaccine as a pre-exposure prophylaxis. But looking back, rabies, we do use vaccine because there is no antiviral. So when there is, in the event that there is no suitable antiviral for pre-exposure prophylaxis, we do use vaccine for pre-exposure prophylaxis. Yeah. Then coming to the post-exposure prophylaxis, this in my heart, I always feel that immunoglobulin should be the way because it's faster. Yeah. So I'm yet not unable to answer why is using post prophylaxis. We are using vaccine because vaccine usually act a bit slower.
Thank you, Dr. Leong. I think perhaps it's good to watch the space. I think things will evolve. Now, I think, Dr. Gayatri, the vaccine, the Genius vaccine is now being recommended for pregnant mothers. What is your take about this? Should we vaccinate? Should we wait and watch? What is the practice?
I think it's still, there's a lot of evolving data. So again, about putting which women is at risk. I mean, COVID is different because I guess it's a pandemic. There was a lot of exposure, airborne. But I think we need to see which populations at risk, which mothers are at risk, and decide maybe we should vaccinate, again, similar to a pre-exposure prophylaxis, and see if we could vaccinate the mother if needed. But going back again, sorry, to Dr. Leong's statement about pre-exposure, we know that it takes, again, 1 to 2 weeks, and this dose, you need 2 doses, 28 days apart. So just say if we give them a person a pre-exposure prophylaxis and they get exposed, so I guess we can give the post-exposure earlier, and then it becomes closer to the less than a month. So yeah, it can work both ways, I guess.
Okay.
I'm sorry, but I think we still need to watch the space and wait for further evolving evidence regarding recommending vaccination for all pregnant mothers at this point.
Okay, there's a question for Dr. Leong. Dr. Leong, the question is the swab. Where should it be taken? Nasopharyngeal or skin? Can the virus be cultured from macules and papules? Okay.
I actually haven't seen the literature comparing which area actually got a higher yield. It depends on which area you can get a higher yield. Personally, if you do not have a skin lesion, then you do the throat swab. I learning from the COVID, nasopharyngeal swab and throat swab of COVID, sensitivity is only 70%. It also very operator dependent. So if I personally, this is my personal view, I first will see that if there is a fluid in the vesicle, then probably we should take the fluid in the vesicle for PCR. It probably get a higher yield. But if you don't have a fluid in the vesicle, it's just a macular-papular rash, then you need to biopsy. In that scenario, maybe on the other hand, the nasopharyngeal swab will be better because you don't have fluid. So it depends on, there is no head-to-head comparison in the literature yet. I will say go by our logic. Wherever you got a fluid, maybe the skin is better. If no fluid, then maybe you can still put nasopharyngeal swab.
Excellent answer. I like the technical details and nuances.
Yeah.
Dr. Leong, you did highlight that incidence of monkeypox is now especially high among those in the sexually transmitted clinics, the gum clinics. Do you think now perhaps this should be the focus where we should perhaps screen when patients who come for STDs with ulcers? What is your take on that?
Yeah, I do agree that we probably need to screen. All the patients come to our STD clinic, we probably have to remember now to palpate for lymph nodes, especially if there is a lymph nodes, we should screen them for monkeypox.
Okay. Dr. Gayatri, I'm going to ask you a challenging question. As obstetrician, me personally, in the last few years, prescribing any medication, be it imaging or be it medication, is always a concern. And people often ask, what is the evidence? What does the FDA say about this? I think you wonderfully highlighted that we need to do more studies on pregnant mothers. So in these complexities, what is the principle with regards to prescribing, especially an antiviral, which is relatively new among pregnant mothers?
Okay, thank you very much, Dr. Manis. So again, we know that theoretically it can be given based on how it works, the pharmacokinetics, the bioavailability, but it's our duty to be safe, and it's something that all of us are very new. If you're going to get a case in Malaysia, it's going to be the first time you're going to see a woman, just say a pregnant woman, get exposed or it's confirmed with monkeypox. It's about weighing again the benefit versus risk, discussing a multidisciplinary approach on what would be the best way forward on treating the condition with the mother. And I mean, and of course, involving the mother herself, that, talking about whether she having the monkeypox infection without being treated might have a worse outcome than having that small possible unknown risk of the drug or the vaccine or the immunoglobulin itself to her and the baby. So again, it's we have a combined discussion and decide which patient would need, and I would accordingly prescribe for the mother. And always looking into further evidence which is available. And of course, as doctors, we need to provide feedback to, if we don't have much cases in our country, providing to international registry can help us learn more about it.
Thank you, Dr. Gayatri. I like your quote, healthy mother, healthy baby, healthy future. So we're almost towards the tail end. The last part, Dr. Leong, take home message with regards to monkeypox. And then Dr. Gayatri for monkeypox in pregnancy.
Yeah, I would say that since we still lose to Singapore, I'm a kiasu person. Probably in Malaysia, any rash, like Dr. Muniz mentioned just now, don't forget about palpating the lymph nodes. And we need more screening. In the event that if patient refuse admission, don't force them. I think we still need to do a swab in the clinic and send more specimen. So maybe one day we probably should identify, then only we know our problem. Now sound like Malaysia is great, we got no problem. We have we probably can say that yeah, without a problem we think we are good, but I'm not sure whether we are really good or not. Yeah, so be vigilance and surveillance. Yeah.
Thank you, Dr. Leong. From 50 countries, it's gone to 75, it's 103 today. I'm sure it's a matter of time before we go on the global map as well. Dr. Gayatri, with regards to monkeypox in pregnancy, your take-home message.
So my take-home message would be, what the mind doesn't know, the eyes don't see. And like what Dr. Leong said, if a mother walks in the door with a rash, sometimes I think lymph nodes might be a bit difficult. She might not have lymph nodes in pregnancy unless she has a hematological condition. Otherwise, so be aware. We have a rash, not sure, refer, ask, test, and I'm sure everyone's happy to receive and co-manage this women. Don't take any, not even monkeypox, infectious disease in pregnancy, a mother gets more vulnerable. I know we're battling COVID, we're coming across, but there are many infectious diseases that makes the mother sick. So let's all learn and continue learning, watch the space on vaccines, antivirals, which we will be updating in our website and our Facebook page. With that, thank you so much.
Thank you so much, Dr. Gayatri. So just to summarize, ladies and gentlemen, the last 1.5 hours, we have learned about the global health emergency of monkeypox. It is spread to 103 countries, 52,000 positive cases. It is something that we are still learning and adapting. Antiviral in pregnant mothers who are vulnerable is not contraindicated. Vaccine has got a role not just for pre-exposure, but also post-exposure. If needed, it is not contraindicated. Work as a team, be vigilant. We can actually prevent severe complications in pregnancy. So with that, thank you so much. Please watch the space. You can log on to our YouTube channel, our Instagram, our Facebook and Twitter. There'll be another webinar in 3 weeks' time. Till then, thank you so much from the Malaysian Obstetric Medical Society. I'd like to thank personally Dr. Leong and Dr. Gayatri all the way from UK. Thank you so much for your time and experience.
Thank you. Thank you very much.